All right, good evening, all. Many thanks for those who are able to join us for this exciting webinar on lipoprotein A. We will be hearing what we already know, what we need to know, and what we hopefully will know in the near future. Most importantly, we will learn how we can apply current therapeutics to individually treat our patients with elevated lipoprotein A. So we'll start by having a lecture followed by a discussion. You can post your questions in the chat, and then we can use these as discussion points. Please note that CME credits are available for this webinar through Opus Medicus, and please do claim the 1 AMA credit or 1 ABIM MOC credit if applicable. I'm going to introduce our esteemed speaker for the evening. Dr. Stephanie Saucier is both a hospitalist and cardiologist in Hartford, Connecticut, and New Britain, Connecticut. After attending medical school at Ross University, she completed her residency at the University of Connecticut. She has over 9 years of experience serving as an internal medicine physician who is also board certified in cardiovascular disease. She often treats many cardiovascular conditions and certainly appreciates the role of elevated lipoprotein A in cardiovascular disease. Stephanie?
Thank you so much for the wonderful introduction, and good evening, everyone. As we all are here to learn a little bit more about lipoprotein A today. So let's start. I'd like to start off with one of a patient case. This is one of my patients. She's a 68-year-old female, and she has premature coronary artery disease. Her first MI was at the age of 49. This was followed by additional percutaneous interventions, stenting, and then subsequently 6 years after her first MI, she required a CABG. She also had significant peripheral arterial disease with aortoiliac disease. She's had bilateral common iliac artery angioplasties. She had a left-sided SFA angioplasty as well. She has a history of diabetes that is well controlled and also a history of breast cancer. She, historically, prior to coming to see me in my preventive cardiology practice, was unable to tolerate significant statin therapy. This was due to muscle symptoms and myalgias. So back in 2016, she was started on Repatha. And I'm going to show you the timeline of some of her lab values. And, this will be a thought-provoking point at what do we do next? So back in 2016, she was on Repatha. She was also on Crestor 2 days a week. That was her maximum that she was able to tolerate. In 2018, she had come off all of her therapy, and her LDL went from 82 on the therapy we had up to 231. Subsequently, in 2019, the Crestor was obviously not reintroduced, and she was started on Zetia at a lower dose, and she had an LDL that ended up at 113. And then in July of 2020, when we first met, she had an LDL of 103. However, she had an Lp(a) of greater than 600 nanomoles per liter. This was on Repatha and Zetia, 10 milligrams daily. And she unfortunately was having ongoing progression of her disease. She required additional stenting after this time in 2020. So, I put the thought out to all of you to start thinking about what would you do next? She's on Repatha. She doesn't tolerate statins. She's already on ezetimibe or Zetia. So what do we do? She's having progression of quite significant disease at a young age, and she's got this Lp(a) at greater than 600. Well, I can tell you what we did. We actually started her on Lp(a) apheresis, as we do have an apheresis center here. And she, since initiation of apheresis, has not had progression of disease since her initiation of apheresis. She typically gets her plasma about 4,500 mLs of plasma treated, and she does come weekly for her plasma for her apheresis sessions. As you can see, these are just some of her labs. Starting back in August, you'll see that she has a really significant reduction in Lp(a) with each treatment. Even, more recently, she will come in and she'll have an Lp(a) 326. And then with a full treatment, her Lp(a) upon leaving is 67. Again, she does come weekly. And as you can see here, she rebounds quite significantly and her Lp(a) comes, kind of roaring back within the next week. And this is while on all of her additional lipid lowering therapy that we've had her on. So I like to illustrate this as a patient who's had quite significant and progressive premature coronary disease that we've been able to stabilize with a combination of therapies that we're going to talk a little bit more about tonight. But let's start with just what is lipoprotein A, or Lp(a), as I'll commonly refer to it throughout the talk tonight. It contains an LDL-like particle that is composed of apolipoprotein B100, phospholipid, cholesterol esters, and triglycerides. There's a unique ApoA that is linked by a single disulfide bond to the ApoB particle. And so you can see it looks similar to an LDL particle. However, it has this ApoA, almost like a tail that's attached to it. And as you can see, there's the regulation of lipoprotein A, or Lp(a). There's a lot of variability. So genetics plays the biggest role, and we're going to talk more about that. Ethnicity and race, medical conditions, environment, all of these things play a role into the Lp(a), how much is actually present in the body. And then the Lp(a), or lipoprotein A, leads to atherosclerosis, thrombosis, and then aortic valve calcification. Again, we're going to be talking about all of these a little bit in more detail as we go on. So as we know, lipoprotein A is an independent and causal risk factor for atherosclerotic cardiovascular disease. The prevalence is 20% of the population. It has an elevated Lp(a). In the absence of an acute illness, the level of Lp(a) is stable throughout an individual's lifetime and is really unaffected by lifestyle modifications. More than 90% of Lp(a) concentration is explained by an autosomal dominant pattern of inheritance and is fully expressed by 1 to 2 years of age, which is shocking to me and probably to hopefully many of you. Lipoprotein A reaches adult levels by the age of 5. So what are the genetic associations with valvular calcification of aortic stenosis? It's something I alluded to on one of our early slides. So patients who are participating in the Cohorts for Heart and Aging Research in Genomic Epidemiology Consortium, it was found that LPA, the gene that encodes ApoA, which is that tail, is the only single gene that is associated with the presence of calcific aortic stenosis. This was actually replicated in independent cohorts as well. And it illustrates that there's a causal risk for both atherogenesis and the onset of calcific aortic valve disease. Now, how does Lp(a), or lipoprotein A, cause disease? It promotes atherosclerosis and thrombosis. The similarity of ApoA to the proenzyme plasminogen increases the potential of LPA to compete with plasminogen for fibrin binding and decrease fibrinolysis. Lp(a) can increase plasminogen activator inhibitor 1 secretion from the vascular endothelial cells. It blocks tissue factor pathway inhibitors and promotes platelet aggregation, all which contribute to increased clot formation. Lp(a) is also a preferential carrier of oxidized phospholipids in the plasma that mediates a variety of pro-inflammatory responses in the vascular cells. And that's how it's proposed to cause disease. Lipoprotein A and coronary artery disease. In patients who had an Lp(a) of greater than 50 milligrams per deciliter, it was found that the risk of acute coronary syndrome is tripled in those aged less than 45 and doubled in age patients 45 to 60 years old. That cardiovascular risk persists despite intense lipid-lowering therapy using statins, with higher risk of MACE in patients who have an elevated lipoprotein A. Cardiac death and non-fatal acute coronary syndrome after PCI was also increased in people who had high Lp(a). And bypass graft stenosis was also seen in patients who had high Lp(a) levels greater than 33 milligrams per deciliter compared to patients who had Lp(a) levels which were lower at 17 milligrams per deciliter. The LPA allele size has an inverse correlation between the ApoA isoform size and the Lp(a) levels. And so again, that LPA allele is the genetics that we're talking about when we're talking about Lp(a). The median Lp(a) levels are higher among African and South Asian ancestry groups. And specifically, the carriers of these two gene sequences, so RS1055872, which we're never going to remember these numbers offhand, or RS3798220, they have fewer Kringle repeats, and therefore they actually have a higher Lp(a) concentration and an elevated risk for disease. What about the association of LPA variants with risk of coronary disease and the implications for Lp(a) lowering therapies? In a Mendelian randomization analysis that involved more than 80,000 patients and 150,000 controls, coronary artery disease risk was proportionally associated with the absolute change in plasma lipoprotein A mass concentration. A 101.5 milligrams per deciliter change in Lp(a) was associated with the same coronary heart disease risk as a 38 milligram per deciliter change in LDL cholesterol levels. So interestingly, the Lp(a) concentration must be lowered by approximately 100 milligrams per deciliter to achieve the same reduction in coronary heart disease risk that can be achieved by lowering LDL cholesterol by 38.6 milligrams per deciliter. Now, when we're talking about lipoprotein A, the role of Lp(a) as a risk factor for stroke in adults is less well documented than it is for coronary heart disease. But it is documented. So in Lp(a), there's one meta-analysis from 2015. There's another meta-analysis from 2021 that I like to reference in these two in talking about ischemic stroke. But 20 articles were analyzed in the 2015 meta-analysis that comprised 90,000 subjects and 5,000 stroke events. And they looked at patients with high versus low Lp(a) levels. The pooled adjusted odds ratio was 1.4 for case control studies. And the pooled adjusted relative risk was 1.29 for prospective cohort studies. High lipoprotein A was an independent risk factor for ischemic strokes based on this meta-analysis. And the relative risk is especially evident in younger stroke patients. And I think this is where a lot of the key important information is for ischemic stroke patients with Lp(a). It's that younger patients really have a significantly elevated relative risk. Sex differences in ischemic stroke still remains unclear based on that meta-analysis. And again, there's another meta-analysis back from 2021 that looked at a number of studies as well, looking at 7,800 ischemic stroke patients in 13 studies. And again, it did find an association between increased Lp(a) and the risk of ischemic stroke. Now, we talked about stroke, we've talked a touch about aortic stenosis, and what about Lp(a) as a risk marker for MACE in statin-treated patients? So there were 7 placebo-controlled statins, randomized controlled trials with a total number of patients of over 29,000, and they were examined for fatal or non-fatal coronary heart disease, stroke, or revascularization across Lp(a) tertiles compared to Lp(a) of less than 15 milligrams per deciliter. And what was found was that the MACE risk was more strongly associated with on-statin Lp(a) than on placebo Lp(a), especially at younger ages. Elevated Lp(a) in statin-treated patients signifies increased risk as well. So how do we measure Lp(a)? As you might have noticed, as I've been talking, even from our case, sometimes I'm talking in milligrams per deciliter, and sometimes I'm talking in nanomoles per liter. And so the measurement is actually quite important when you're referencing or discussing Lp(a). It's recommended that we start adopting a particle concentration, which is the nanomole per liter, versus the mass concentration, which is the milligrams per deciliter. And the reason why is because we're unable to interconvert accurately between, because using a common conversion factor actually underestimates the smaller isoforms. This should allow standardization and harmonization of assays, balanced clinical studies. So when we're comparing one study to another study, it's easier to really see the interaction based on levels that we're all talking the same language and the same units, and facilitate evidence-based guidelines. So it is, recommended that we all come and adopt one of the measurement mechanisms of specifically the nanomoles per liter. Now, there's some things that we talked about what we know about lipoprotein A, but there's still a lot of things that we don't know about lipoprotein A. So what about ethnic group specifics? Some of the largest studies compared African American and whites. What about sex? There's, a thought that there's lower risk in women. What about primary versus secondary prevention? Are their treatment goals different for patients? How about comorbidities? What comorbidities are going to have an interaction with lipoprotein A, such as thrombophilia, diabetes, FH, renal disease? And so I think it's important for us to recognize that there still is a lot that we don't know when it comes to talking about lipoprotein A. Now, this is another question I put out to the group, and just to kind of get you thinking is, do you think everyone should be tested? Some of the key thought leaders in the National Lipid Association support checking an Lp(a) at least once in a lifetime. And the European Society of Cardiology and the Canadian Cardiovascular Society both recommend that Lp(a) be measured at least once in adults. So what former treatments have been evaluated for, these patients? There are a couple, we've been working on this. So mipomersen was first looked at. This was an antisense oligonucleotide, and it was against the ApoB100. It reduced Lp(a) levels by about 20 to 30%. However, it had significant hepatotoxicity, and it was discontinued, and research was halted on this. And it never made it to market. Lometamide, excuse me if I butchered that, but it's a microsomal triglyceride transfer protein inhibitor that was evaluated. It inhibits the VLDL and thus lowered secretion of ApoB100 containing lipoproteins, found about a 15 to 20% reduction, but again, had significant hepatotoxic effects and also did not make it to market and does not have ongoing studies. So when we talk about, who needs to be tested, we saw that the European Society and the Canadian Society recommend testing everyone once in a lifetime. What does the National Lipid Association think? So this comes from the National Lipid Association, and level of evidences are over in the right-hand side, but recommends individuals with a family history of a first-degree relative who has premature ASCVD, individuals who have premature ASCVD themselves in the absence of traditional risk factors, individuals who have primary severe hyperlipidemia, LDLs greater than 190, or suspected familial hyperlipidemia, individuals at very high risk for having ASCVD, borderline or intermediate 10-year risk when the decision to use a statin is uncertain, to improve your risk stratification and primary prevention, less than anticipated LDL-C lowering despite good adherence to therapy. If patients have a family history of Lp(a), or which is what we commonly call cascade testing, and calcific valvular aortic stenosis, because as I mentioned before, this is a risk factor for that calcific aortic stenosis, and recurrent or progressive ASCVD despite optimal lipid lowering therapy. So this is where the NLA sits in terms of recommendation. But again, some thought leaders recommend that everyone be tested at least once in their lifetime. So I'd like us to take a look at this paper, which looked at the effect of alirocumab on Lp(a) in cardiovascular risk after acute coronary syndrome. And I'm going to kind of just hit the highlights, but PCSK9 inhibitors lower Lp(a) concentrations by approximately 25%. Alirocumab-mediated Lp(a) reduction showed benefit in MACE reduction independently of the LDL lowering effect. Now, the mechanism is not completely known. However, the LDL-C receptors may be playing a role in the removal of Lp(a) when an LDL level are low and the LDL receptors are high. You can see here that the baseline lipoprotein A quartiles is a predictor of events this is a predictor of MACE. So obviously patients who are in the fourth quartile had the highest risk or 12.5% incidence of MACE. Coronary heart disease, death, and non-fatal MI, same thing. The fourth quartile really is what is significantly elevated. Interestingly, in this paper, ischemic stroke, not clinically significant, cardiovascular death and all-cause death, not statistically significant for across the quartiles. Now we're going to look at the Odyssey outcomes. So the proportion of MACE reduction attributable to changes in Lp(a) and corrected LDL-C. And as you see again on the base, we're going to see on the x-axis, you're going to see that the baseline Lp(a) percentiles are the 25th, the 50th, and the 75th. That 75th percentile are patients who had a baseline Lp(a) in the milligrams per deciliter at 59.6. And so I want you to look all the way to the right-hand side, and you can see that the percent MACE reduction attributable to the LDL-C reduction was 73%, and a 27% reduction of MACE attributable to the Lp(a) reduction. And again, this just goes to illustrate that even more. Alirocumab is better compared to placebo in all of the quartiles, except the first quartile where you're, it does cross the median line. But overall, patients' absolute risk reduction was improved for MACE. Now, what about all the other drugs that I mentioned that my patient was on, right? She tried statins, we had her on PCSK9 inhibitor, we had her on ezetimibe. Well, statins have minimal or a mild increase in Lp(a). However, rosuvastatin 20 milligrams daily reduced ASCVD risk equally in all ethnicities, whether the Lp(a) was above or below the median. Ezetimibe had a minimal decrease as reduction of Lp(a) level as monotherapy, and we don't know effective ASCVD outcomes. The PCSK9 inhibitors, as I just illustrated, evolocumab decreased by a median of 27% Lp(a) levels, reduces the relative risk of coronary heart disease death, MI, or urgent revascularization, 23% if the Lp(a) is greater than 37 nanomoles per liter, with the number needed to treat of 40, versus those with an Lp(a) of less than 37, and again, a number needed to treat of 105. Alirocumab decreased Lp(a) levels by a median of 29%, and the proportion of MACE reduction attributable to changes in Lp(a) was greatest in those who had an Lp(a) level greater than 59.6 milligrams per deciliter. Again, as you can see, there's changes across the measurements. So what about the NLA? What do they recommend for an expert panel recommendations for treatment? We'll start with niacin. So niacin actually, which lowers Lp(a), is not recommended to reduce ASCVD risk in patients receiving moderate to high intensity statins plus or minus ezetimibe who have an LDL-C level of less than 80. In high or very high risk patients who have an Lp(a) of greater than 50 milligrams per deciliter or greater than 100 nanomoles per liter, it's reasonable to consider more intensive LDL-C lowering to achieve a greater ASCVD risk reduction. In very high risk patients, taking a maximally tolerated statin with an Lp(a) of greater than 50 milligrams per deciliter or greater than 100 nanomoles per liter, the addition of ezetimibe is reasonable in those patients with on-treatment LDL-C levels that are greater than 70 or the non-HDL is greater than 100. In our very high-risk patients, taking a maximally tolerated statin and ezetimibe with an LDL-C of greater than 70 milligrams per deciliter and an Lp(a) of greater than 50 or 100. The addition of PCSK9 inhibitor is also reasonable. And in high-risk patients, taking a maximally tolerated statin with an Lp(a) greater than 50 or 100, the addition of ezetimibe may be reasonable in those on treatment. Now, as I mentioned before, we still don't have all of the answers. So what about Lp(a) and secondary prevention? We know that lipoprotein A is associated with an increased risk for recurrent events, and that most lipid risk reduction related risk is still attributable to LDL-C. So we still recommend continuing to follow guideline therapies, consider more aggressive LDL-C goals for your patients who have increased Lp(a), and consider earlier use of the PCSK9 inhibitors based on the data that I illustrated earlier on. So what about kids? I sit here and I say past first degree relatives. So that would mean if a parent had Lp(a) that was elevated, the kids should be tested or cascade screening. Well, if you find a child who has a high Lp(a), then reverse cascade screening of first degree relatives is important. So if you have first degree relatives who are still living, then we recommend screening them. Heart healthy lifestyle implementation is really important in children. And then if children are less than 20 years of age, measurement of an Lp(a) is reasonable if they have clinical suspected or genetically confirmed familial FH. If they have a first degree family history of a relative with ASCVD less than 55 years of age in men and less than 65 in women, and if they have an unknown cause of an ischemic stroke, it is illustrated more in the pediatric literature that Lp(a) is a significant risk factor for stroke in children, and a parent or sibling found to have an elevated lipid Lp(a), so cascade screening. Now we talked about some of the medications. Let's talk about lipid apheresis for Lp(a). As I mentioned, my patient is on lipid apheresis and she does excellent and has not had any progression of her disease. It's the most effective treatment available. It lowers Lp(a) by 60 to 80%, as I showed you on the slide with my patient, and is associated with significant MACE reduction in individuals who have progressive ASCVD. The PRO-A Life study also illustrated this. Now, the problem with lipid apheresis is it's less accessible and it is more intrusive to the patient's day-to-day life. My patient, she does come in weekly for her sessions. The FDA has approved the use of apheresis in individuals with ASCVD who have an LDL of greater than 100 and an Lp(a) of greater than 60 milligrams per deciliter. This paper also illustrates that. This was a prospective observational multicenter study. It included 170 patients who had Lp(a) and progressive cardiovascular disease. Lipid apheresis has a lasting effect on prevention of cardiovascular events in patients with high Lp(a). And it was found in this that regular ongoing apheresis was associated with stabilization of progressive disease. This is exactly what we saw in my patient. She had progression disease on all of the medications I could put her on, but then she actually has stabilized out and has had no additional progression of her disease since initiation of apheresis 3 years ago. The annual incidence rates for MACE and ACVD were 855 and an 81% lower during chronic apheresis in comparison to progressive phase of prior to starting apheresis in this study. And Lp(a) concentrations seem to comprehensively reflect Lp(a) associated cardiovascular risk. Now, what about these new drugs that are currently being tried and are in phase 3 clinical trials right now? So we have the antisense oligonucleotide against Lp(a), and we also have a short interfering RNA therapy. These target hepatic ApoA production, and they have demonstrated significant reductions in Lp(a), anywhere from 60 to 90%. So currently, there's 2 drugs that are in phase 3 clinical trial, pelacarsen and olpasiran. And pelacarsen is an antisense oligonucleotide against LPA, excuse me, and olpasiran is the siRNA therapy. There are also 2 additional drugs that are in phase 2 clinical trials currently. So there's hope for our patients who have a high Lp(a), and hopefully we're going to see some really positive effects from these phase 3 clinical trials. Another question that I get asked a lot, and something that we talk about with many of my patients, is what about antithrombotic treatment? What about primary prevention? Low-dose aspirin has been effective in lowering the risk among patients who have ASCVD, as well as primary prevention. This is something that we know. Now, there's a possible link to aspirin lowering Lp(a) levels through reduction of ApoA production in hepatocyte cultures. However, this is possible, and we still need more studies to really define this. The SPREE trial, there was a sub-study that showed patients with Lp(a) polymorphism had a 46% relative risk reduction for combined endpoint of MACE when they were on aspirin. And patients with an elevated Lp(a) benefit more from a low-dose aspirin therapy than the general population for primary prevention of ASCVD. So that begs the question, should all of these patients who have a high Lp(a) be started on a baby aspirin for primary prevention? Additional randomized controlled trials are still needed. However, this is something that, a lot of us put into play in our own clinical practices. What about the future? So we've talked a lot about what we already know about Lp(a), what we're still hoping to know, that there's not all the answers are here, and where the future lies. So Lp(a), we know that this is undermeasured and underestimated across the spectrum. Although the prevalence is thought to be 20%, we know that people are only getting tested, in the single digits, 1%, 2% of the time. It's really important, as you guys are all here with us tonight, that we increase awareness, that we increase cascade screening. So when we identify patients with high lipoprotein A, that we're able to test their first degree relatives and bring awareness and hopefully intervene at a much earlier point to try to protect them. And also in the future, we need to focus on optimizing the management of additional cardiovascular risk factors, and see where a lot of these new drugs and trials take us. And, again, it's a very exciting time in terms of hope for the future for these patients who are significantly affected by lipoprotein A. But I hope that you learned something, took something away from this talk. And now we actually have some good time to get into a discussion, answer some of your questions, and kind of go from there. So with that, I will turn it back over.
Okay, great talk. Actually, I learned a couple of things myself there too. Please do post your questions so that we can respond to them, because there's definitely a lot of good material there covering a lot about lipoprotein A with regards to screening, diagnosis, and treatment. So I'll just start out by asking Stephanie a question. It's interesting that the case that you brought up, this woman had a very significant peripheral arterial disease, as well as the very significant coronary artery disease. Her bypass grafts, as you said, went down. Her LPA was quite elevated. So, as we know, PAD is a very high risk ASCVD condition. Should we be screening all patients with PAD, or really only the ones with a family history of early heart disease?
That's a great question. And so, my take is that I really believe in the school of thought that we should be testing everyone. If there are people who have significant peripheral arterial disease and we don't have a clear, solid reason, right? They're not 80 years old and have smoked 60 pack years. Those patients obviously might not necessarily need an Lp(a) to be tested. They've already lived this long. But in those patients who you have in your 40s and your 50s, who you're getting claudication symptoms and you're getting peripheral arterial disease, or you have carotid disease already, my opinion would be to test them, because I think that with the future, not only just for the patient themselves and for the potential that we have to treat them, but also for their children, their significant others, right? Meaning their siblings, their first degree relatives. I think it's, the cascade benefit of testing these patients is incredibly important, and hopefully could protect someone in the future from being in the same situation that they're already in. So that would be my take on it. What do you typically do in your practice?
I agree. I think we should be screening everybody at least once in their lifetime, and that's all they need. All they need is one measurement. So I think definitely a greater focus on these patients who are higher risk and have advanced disease. But certainly everybody should be screened, particularly if there's a family history. And clearly, this patient benefited from apheresis, which with dramatic improvements. So, and it's interesting that she's receiving weekly apheresis therapy because she just doesn't have any options right now. So we have another question from the audience. The question is regarding the 5-year study that you presented for apheresis. How often were these patients receiving apheresis? And can you comment on the impact of nutrition and exercise on lowering lipoprotein A?
So in the 5-year study for apheresis, most of those patients were receiving apheresis every 2 weeks. And so that was the common practice, was every other week for those patients. My patient does get apheresis weekly. And again, you could see how quickly she rebounds, right? So she started off at greater than 600 in 2020. Now weekly, she rebounds back into the 300, 400 range. So that's why we chose to treat her weekly. But in that specific study, it was every other week treatment for LPA. And then Dr. Hirsh, you want to take the impact on a nutrition and exercise question? Otherwise, I can too.
Yeah, sure, sure. So, first of all, I mean, I think, when you think of nutrition and exercise, you really think of our primary therapies against the progression of coronary artery disease or peripheral arterial disease. People often forget that really this makes a huge impact on everything, and that's really taking a step back from LPA. Now, does it lower LPA? Probably not.
Right.
And I haven't seen anything that demonstrates a lower LPA, but statins actually increase LPA levels. So, and they're beneficial, and we don't stop them because they increase LPA levels. We continue them because they reduce LDL and atherosclerotic cardiovascular disease risk. So I would say that that's still very important and still cornerstone, but it may or may not, and likely do not lower LPA levels, which is genetically mediated.
I completely agree with you. In addition to my spiel on initiating, medical therapy in these patients, I still give the same recommendations for, lifestyle modifications from a primary cardiovascular benefit.
Right, exactly. So I agree completely with that. So this is a more of a high level question. Sounds like if from a genetic standpoint, is there genetic polymorphism in LPA with some forms being more noxious? Um, is there a way to screen for more noxious forms, not just LPA level? Do you feel it is enough to assume if a proband has a high LPA and has events, if you screen the relative, is the LPA high enough and LPA is high, they have a real risk? I can try to start off answering this question. So I think there are certainly genetic polymorphisms in the ApoA gene and the way that and the difference in Kringle repeats ultimately determines the LPA level. But I don't think there is any, at least to my knowledge, literature on the difference between ApoA, certain isoforms, and having a greater impact on outcomes than the level. However, I could be wrong. What do you think, Stephanie?
I agree with you. So in, prepping this is a very common question. I think we get asked a lot. And I agree. There are, certain polymorphisms and alleles that have more Kringles and have this higher risk. But I'm not familiar with, specific ways to screen for that, other than identifying that these, as a whole, the lipoprotein A population, when they're elevated, is at increased risk. So I'm not 100% sure on that one, but it's a great question. And I think we'll probably learn more over time, right, as time goes on.
Yeah, I actually want to reiterate, it is a very good question because really diving into the genetics of all of this is going to be increasingly important. But right now, I think for general purposes, the LPA level is what really is reflective of the risk. Okay, so and this is a good question. Do you trend LPA once therapy is initiated?
That is a great question. So I do not, when I initiate therapy with either a statin or a ezetimibe, I don't trend Lp(a) in that instance, because I find patients get nervous, right? Even they know that this is a risk, but then we also know that statins raise Lp(a) a little bit. So I don't test Lp(a) again in that instance. Now, when I initiate PCSK9 inhibitors, I typically do like to check, usually just once. It's not something I continue to trend, but I like to check to see, hey, did we get a significant reduction, right? Is it because we have this LDL that's down so high and we have all these new, LDL receptors working to lower levels. So when I initiate PCSK9 inhibitors, I do check. When I initiate statins, ezetimibe, I don't check. And when my patients are on apheresis, I do have a few who are on apheresis, they get an Lp(a) level at the beginning of their treatment. And then when they complete treatment, we also pull an Lp(a) level. Again, I like to make sure that we're getting an appropriate reduction with their treatment. What about you? How do you handle it?
Yeah, I agree completely. I think that we measure it, and then we treat for it. If, and with current therapies in particular, and you're not going to see the level of, you're often probably going to get some level of disappointment or frustration that, great, maybe I've had some reduction in LPA, but I still have, 50% more reduction I'd like.
Right.
Or I'm not getting any reduction in LPA, but I'm still on a good therapy that's treating my risk. Either way, that really becomes something that is disappointing to the patient, and really doesn't affect our treatment. So I think that I don't trend LPAs. Now, for the patient that you presented who, like you said, in apheresis, where they're committing to a weekly, treatment that where they had to take 3 hours for the treatment itself, and as well as the commitment to go to and from home or work. That's something where we, of course, if it's directed specifically to LPA, then you want to know the outcome. But for most purposes, I don't trend them.
Agreed.
So do you want to take the one on Southeast
Yeah.
Asian heritage?
So we've got another question. This one is, patients of Southeast Asian heritage have an increased incidence of Lp(a). Since there is increased cardiovascular disease in this patient population, is it appropriate to measure Lp(a) in these patients? Yes, I completely agree, and I really recommend everyone be tested. Everyone should be tested for Lp(a) at least once in their lifetime. And so this patient population, especially, right? So some of these patients, I also, really, in my practice, we test everyone for Lp(a), but I also make it a point in some of your higher risk patient populations. So, for example, women who have a history of preeclampsia during pregnancies, right? Those patients have increased risk of having cardiovascular disease. They should be tested for Lp(a) because they already have risk enhancers. The Southeast Asian heritage, those patients already have an increased risk. So if you already have one increased risk, you really want to know what other risk enhancers you're dealing with to better treat these patients, in my opinion.
Yeah, I agree. I mean, that just kind of we would I would test this in every patient to begin with, but certainly that ups the ante in terms of testing. Okay, so the next question we have here is, in a scenario where the patient is in their 30s, risk factors with hypertension, hyperlipidemia, and LDL of 105, uh, and LPA is elevated, would you treat this patient? Um, so this is definitely a nuanced question. So do you want to start with this?
I'm happy to start. So I would, yes. In this, I would treat this patient they're young, yes, but they also have risk factors. They have an LDL that is, I would want to make their LDL quite a bit lower. I really would like their LDL, less than 70, kind of as low as I could get it, if they had a high Lp(a). That's how I would approach it. How would you?
Yeah, I agree. I think that we're starting to recognize, I mean, certainly there's more that I would like to know about this patient, what's their family history? Are there other metabolic risk factors that put them at higher risk? To already have hypertension, already have hypertension, but and how elevated is the LPA? And that's an interesting question in itself. What's the threshold? But either way, what we're learning is that treating LDL to very aggressively is not most evidence has shown that it's not harmful, and that in fact it's beneficial for the long term. So if you have another reason to treat LDL, then certainly I would treat the LDL and LPA. So let's see here. We still have another 15 minutes or so. Please feel free to put out some questions. Otherwise, we can kind of just talk amongst ourselves about some of the things. We talk, okay, oh, we got another question coming
Exactly.
through. In the scenario of the patient in their 30s, if they had a calcium score of 0, would that change your approach?
Do you want to take this one first?
Sure. So one is I probably wouldn't check a calcium score. Uh, it's now, that being said, oftentimes you get a request to check a calcium score. It's I would still treat the patient because the American Heart Association just came out with a 30-year risk score for patients, and that's how they're thinking. We're thinking much longer term, and oftentimes, um, CT calcium scores are going to be eventually potentially supplanted by other scores where there are technologies that are looking at um, whether or not you got atherosclerosis by just doing an ophthalmologic exam and looking at the arteries, looking at the carotids, the arteries we can't see in the brain. So, they could have plaque elsewhere, and I don't think it would change my approach. I think that it's kind of false reassurance.
Dr. Hirsch, I couldn't agree more with you. I think it's also really important to remember that younger patients, although they may have a calcium score of 0, that means that they have 0 calcified plaque, right? That doesn't take away the soft plaques that are more common in the younger population. And so it's not that this patient has 0 plaque. So I agree, it wouldn't change my approach. I still would treat that young patient with high lipoprotein A. Again, we want to get some more information on them, but kind of as a whole, I would still treat them quite aggressively.
Absolutely.
A really interesting question that I got asked this week, actually, it was, does pregnancy increase lipoprotein A levels? And what do you do about a woman if they're tested, if they somehow get tested their LP(a) while they're pregnant? What do you do? So that was an interesting question I got this week from one of my patients.
Yeah, no, that's interesting. It's always interesting, when it comes to pregnancy and we have to really say, okay, well, I'm sorry for these 9 months, or plus, we're gonna have to stay away from treatments at this point. But just kind of reassure the patient that in that small time frame in the scheme of life, obviously we don't we're concerned about the effects on the fetus and we will hold off, but that's just a small that's just a small length of time in the scheme of cardiovascular prevention.
Exactly. And so I do a lot of reassurance in these women. But it is interesting that sometimes we do see elevation in women who have an LP(a) in their pregnancy. And there's some thought that it has to do with the estrogen production of the ApoA particle. So very interesting. Just like I said, I think there's still a lot we don't know, but reassure them and get them through their pregnancy with as little stress as possible, is usually how I take it.
Yeah. So since there's no other question, I'm gonna pose a question to you about that case. The that patient, I can't recall what that you presented with the who had PAD and bypass graft failure. What was their LDL?
So her LDL wasn't terribly high. So initially, her LDL off, I mean, I don't say not terribly high. So her LDL prior to Repatha, okay, so she had in 2018, she went off of therapy completely, and her LDL went up to the 160s, and that was off of all therapy. So it wasn't like she was a LDL of 200, 300, right? On Repatha, her LDL on Repatha plus statin, her LDL came down into the 80s, which was the lowest we got her. But off of therapy, she's like I said, in the 160s range. So not terribly high. And then each week that she comes in, her LDL is in like the low 100s when we start her there, when we start her sessions.
Yeah, and and certainly I think that currently that there's the indications are that LDL be greater than 100 and LPA be greater than 60 milligrams per deciliter. But I think that's right. It's greater than 60 milligrams per deciliter. The it's interesting though. I have another patient whose LDL is controlled. I think it's in the 30s, and her LPA is in the 600s, and also having it had just had bypass graft. Literally 7 months after she had her bypass surgery, her bypass grafts have gone down. So I'm trying to, and I know there's been some success in getting some of these patients apheresis therapy if you can't enroll them in some of these cardiovascular outcomes trials. But I do think that's worth pursuing. Certainly in Germany, they're doing it for basically all patients. So I think that Europe is always first to to try
Yeah.
something, and then we follow.
Yeah, I have had success with a couple patients who had LDLs that were controlled, however, progressive disease and really high LP little A's that I have gotten approved for apheresis. But it's a challenge, and I think that that's something that we as a cardiovascular community should really kind of hope to change, right? Because until these other pharmaceutical treatments become available in a patient like yours, apheresis is going to be the way that you protect that patient for a prolonged period of time. So I'm hoping that they get rid of the needing to have an LDL greater than 100, as part of the FDA requirement. I'm hoping, but we'll see where things kind of lead in the future.
Yeah, I'm hoping so too. It's hard to watch these patients and just wait for cardiovascular outcomes trials or wait for indications to change. So certainly I think that that would be a major change if they could, especially with these people who are really have advanced disease, as in your patient and my patient.
There's also been some studies on patients who have had transplants, because of ischemic heart disease. And those patients developing CAV, right, because of their high Lp(a) in their new hearts. So there's some data there as well, which I think is, again, it just goes to show you that this is genetic and progressive, and it's something that we really need to know more about and really treat.
That's actually very interesting. I didn't even know there were studies on that because I've done a lot of work with PCSK9 inhibitors on the patients with you said the stands for cardiac allograft vasculopathy, and their use and how they're safe to use in that population. So yeah, I mean, what do? You transplant someone with an LPA of 600, and then they're they're and then newly transplanted heart starts to develop disease. So that's you're still not addressing the root of the problem.
Exactly. Exactly.
Well, we have a 5 more minutes or so. If any last questions from the audience? Okay, Stephanie, any last words?
I just wanted to thank you all for joining us tonight. I hope you took away some interesting things from this talk, and I hope you start checking LP(a) in everybody.
Yeah, and Stephanie, thank you very much for this really great talk. I learned a lot, and I hope you guys learned a lot about some of the need to test LPA much more, and how it can inform your clinical practice, as well as some of the newer treatments that are coming about. So please feel free to reach out to either of us, and thanks very much for joining us.
Thank you so much, Dr. Hirsh.
Thank you, sir.